Hi and welcome to the 9th episode of the Neuroendocrine Cancer Nutrition series. This episode's on surgery and the pancreas. So the pancreas has got several roles. The two main roles which affect our nutrition are the production of hormones which raise and lower our blood glucose, and secondly the production of digestive enzymes which break down our food. So there are different types of pancreatic neuroendocrine tumour. So these include glucogenomas, lipomas, gastrinomas, somatostatinomas, insulinomas, and also there's the non-functioning, the non-hormone producing neuroendocrine tumours of the pancreas as well. Some of you, if you have a pancreatic tumour, may be offered surgery, and the different forms of surgery are distal pancreatectomy, which removes a tumour from the tail or the body of the pancreas, a classic Whipple's or modified Whipple's, which we call a PPPD, which removes a tumour from the head and or the neck of the pancreas, a total pancreatectomy, which removes all of the pancreas, and then there's kind of a scooping out of the tumour, which is called enucleation. Then there's less common surgeries which involves doing a bypass. So the kind of nutrition that you should expect after surgery really depends on what kind of surgery that you have. So for example, the Whipple's operation is a really long operation and it does take a long time to heal because we're talking about healing several different organs. Most people will be on parenteral nutrition, which is feeding a fluid directly into the bloodstream. Other less kind of severe operations will involve just using a feeding tube directly into the small bowel. When parts of the pancreas are removed, patients may have significant long-term adaptations to make. So what you have removed, including the pancreas and the other organs, determines the long-term side effects that affect nutrition. So firstly, there's something called dumping syndrome which can occur. So if some of your stomach is removed, you may suffer from dumping syndrome because food can't hang around too long in the stomach anymore, and therefore the food is just dumped on the duodenum's doorstep without much warning. This is called early dumping syndrome. Late dumping is due to a sudden drop in blood glucose 2 to 3 hours after you've eaten a meal, and this is due to a sudden raised level of insulin which suddenly drops the blood glucose. I'll do a separate episode on gastric surgery. If either are a problem for you, you do need to start having about 6 small meals a day, sip fluids throughout the day. Don't drink a glass of water or a cup of tea really quickly. It's all about sipping. No drinking competitions. And also you need to avoid really sugary foods and drinks. So secondly, pancreatic exocrine insufficiency. So this can be caused by a few factors. For example, the somatostatin analogues or the subcut injections of octreotide that you're having. Surgery, of course, and just simply having a tumour that hasn't been resected. So severe insufficiency results in steatorrhea. This is your stools becoming yellow or beige coloured due to undigested fat, protein and carbohydrate. When we look at patients with all types of pancreatic cancer, including those with neuroendocrine cancer in the pancreas, pancreatic exocrine insufficiency in fact is found in between 68 and 92% of patients before surgery and in about 80% after surgery. If you've had a total pancreatectomy, you will require pancreatic enzyme replacement therapy. If the head of the pancreas has a large tumour in it or it's been removed as a result of the Whipple's operation or the PPPD operation, you will require pancreatic enzyme replacement therapy. Patients having the body or the tail of the pancreas, though, will be monitored for signs of them developing malabsorption, so may or may not require enzymes at some point. So the extent of the pancreatic resection is an important denominator for the development of pancreatic exocrine insufficiency. So let's use the reconstructive surgery after a Whipple's operation as an example. So Whipple's may lead to a reduction in exocrine pancreatic secretion due to the abnormal cholecystokinin release after eating a meal. So cholecystokinin is something that's released from the small intestine after you eat food. There's also the problem with gastric emptying and the pancreatic secretions in the small intestine not pairing up at the right time. So if they're out of sync, this may result in the improper mixing of enzymes and chyme, which is something that's called secondary exocrine insufficiency. So the other thing that can happen is that the stomach and the duodenum can start producing too much acid after these operations. And if there's too much acid in an area which isn't normally acidic, it basically stops your enzymes from breaking down any food. It denatures the enzymes. You should already be on a proton pump inhibitor drug to reduce this acid if you've had something like a Whipple's operation. This helps the enzymes work well as preventing dangerous ulcers in the duodenum and the stomach from forming. As well as all of this information, please watch episode 1 for the full information on pancreatic exocrine insufficiency. So on to micronutrient deficiencies after having pancreatic surgery. So if you're not absorbing fat, it can lead to weight loss and micronutrient deficiencies of fat-soluble vitamins A, D, E and K. Selenium, iron, zinc and copper deficiencies are also possible if large amounts of the duodenum are also removed. Patients having a total pancreatectomy will probably need vitamin B12 injections every 3 months after the operation. Patients having part of their stomach removed, for example in the Whipple's operation, are also at risk of B12 deficiency because of the reduced intrinsic factor being made. Please check and discuss with your medical team, as injections may need to be set up and arranged before you leave hospital. There are also reports of calcium absorption being affected by pancreatic surgery too. All of these deficiencies will be treated with oral supplements or injections. Just echoing previous episodes, it is most ideal to get these vitamins and minerals monitored. Otherwise, you can prevent or treat something just based on guesswork. So if you do have access to these blood tests, then please do use them. So on to diabetes. So diabetes develops instantly after a total pancreatectomy because all of the insulin producing cells that reduce our blood sugar have been removed. But for other operations it can take a while to develop, and not all patients after having pancreatic surgery will develop diabetes. Have a chat with your GP or your neuroendocrine cancer team if you're concerned about your blood sugar levels after the operation. If you are diagnosed, you may be started on insulin injections to replace the insulin your pancreas would have normally produced. A good diet will help control your diabetes in combination with regular insulin injections. You'll ideally need a consultation with a diabetes dietitian though to help you learn about carbohydrate intake and insulin dosing. So also, as you'd expect, weight loss is also common after pancreatic surgery. If weight has become an issue, there's something called MCT oil or medium chain triglyceride oil, which may help control weight loss in patients with uncontrolled malabsorption. MCT oil is a calorie-rich type of fat that bypasses the normal fat absorption route and is readily absorbed in the body. It's found naturally in coconut oil and palm kernel oil, and it's added to some prescribed nutritional supplements. It can be purchased just alone as an oil or as a nutritional supplement. A high protein diet and the use of other oral nutritional supplements may also help promote weight gain, increase your strength, ability to exercise and improve your quality of life. You may still need some enzymes with all of these supplements though. So that's it for this week. Tune in to episode 10 next week.